It's 3 a.m. You've been working hard, picking up where the evening shift left off. You're finally making a dent in the waiting room. You've got treatments underway, and you're making dispos happen. You're finally catching up, and you can almost feel a lull now. And a new patient pops up. A young infant. Chief complaint: increased crying, or won't eat, or constipated, or he looks sad. Okay, let's put him in a room and we can do a quick dispo. I just got my waiting room looking good after all. But wait, this may be your most dangerous patient tonight.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horachko. Many parents, even those who are experienced or savvy, they can quickly become upset or worried and bring in a young infant for seemingly benign reasons, or that's what we want to believe. The truth is, people do the right thing for the wrong reason all of the time. Instead of entertaining a fleeting feeling of annoyance or taking a dispassionate, neutral, treat 'em and street 'em approach, here's my advice. Slow down. Slow way down. Our biases, our limitations in communication or assessment, our external pressures may be pushing us to do the wrong thing for the right reason. That is, a quick dismissal of the seemingly well infant. Now, of course, we are not talking about the obviously undifferentiated sick infant. Take a listen to that episode of the Playbook for a rapid stabilization and intervention. What I'm talking about right now is actually a more dangerous presentation. The obviously sick kid. You're going to use all of your B.Pharm superpowers to take care of that child, or just to start things and get more hands on deck. The stable, well-appearing, or really just fussy infant is the one that can have the serious illness that we miss. We can brush it aside very easily. Why? Well, we've talked about our built-in biases. Some things just don't help us. The context of the visit, or extraneous personal details of the patient or the family, or maybe the parents are very young or unable to explain as well as we would like them to explain. Or the staff happens to be a bit more, say, bristled that night. All of those things don't help us. In fact, they work against us. The young infant is pre-verbal. Even his body language is limited. But I encourage you to take that moment to slow down and really let your observational skills shine. You can't see what you don't stop to look at. Your gestalt is hungry. It needs to be fed. It lives on observation. Feed it. Feed it a lot and feed it often with small observation appetizers throughout the day. The more you practice intentional observation, the more it becomes unintentional, automatic. You'll be amazed at the savory subtleties that will save you a bout of diagnostic indigestion later. One way to think about the seemingly well but fussy infant who comes to our ED is this. Lots of roads lead to badness, but many more lead to everything turning out all right. We need some kind of rules of the road, some traffic lights to get us there. Red light, yellow light, green light. Red light. We've talked a little bit about when we should stop and recognize an ill patient. Sometimes we see an obvious red light, like a fever in a neonate, or inconsolability, or some unexpected finding or result that will make us stop and change our path. No matter how reassuring the neonate with a fever is, he needs a workup, treatment, and admission. Or the inconsolable young infant who appears to be fussier the more that you try to console him and soothe him, and then he settles down when you leave him be. Paradoxical inconsolability and meningitis. Stop right there. Red light. Work up, intervene, admit. Yellow light. Well, maybe you don't see a red flag, but you do see something that causes you to take extra caution in proceeding. Maybe this is the 2-month-old who has recurrent vomiting but looks well. You feed him, and he vigorously takes it, only to vomit it all up right away. Pause. It's easier when there's projectile vomiting, but now you're really thinking pyloric stenosis. For these in-between cases, we probe with more history, and we invest a few more minutes in a very careful, thorough, head-to-toe physical exam. It doesn't take long to get a history. They don't have much to tell you in their young lives. And as far as the physical exam goes, the real estate is all right there. After we do a good H&P, if we need to do some screening labs, that's just fine. Just remember, in adults, we have a very low threshold to send screening labs. Adults have had the opportunity to collect more and more medical conditions. In otherwise well children without comorbidities, we can screen if we see a yellow light. The fussy, vomiting 5-month-old girl. Nothing else is going on, but could this be a UTI? Green light. Finally, for the children you feel comfortable with, parents may just need good counseling and reassurance. We have to have a good backup plan because things will change. Be specific and be explicit. Follow up at a particular time and date and place. All of that is important. Call your doctor the first thing in the morning and make an appointment to be seen tomorrow at, say, 9 a.m. If you can't see him, ask his office if one of his partners can see you. Otherwise, we're always here for you. Or, some variation of that. Even the most benign-sounding cases need a very explicit plan for self-care, for follow-up, and precautionary advice, both written and oral. It's good medicine and will save you in the inevitable event when bad things happen to good people. We've been taught in school and training that history is everything, and it is important. But in nonverbal children, there's a difference. We're dealing with a filter. The parent or caregiver will color their account depending on all of their past experiences, their fears, their concerns, and their angst, or what have you. It turns out in young children, history is important, but physical exam trumps that. In a study by Poole in Pediatrics, the investigators looked at 56 infants with acute, unexplained, excessive crying. These were children without a fever or without a cause that was known to the parents. 60% of these cases were associated with some serious diagnosis. So the cohort study here included some potentially ill children. In 20% of cases, the diagnosis was revealed by history. Physical examination made the diagnosis in 40%. An additional 13% of cases had major clues to the diagnosis on physical examination. What does this mean? In contrast to adults, where, as the saying goes, the diagnosis is made by history, in children it seems to be just the opposite. At least according to this study, in over 50% of cases, the physical exam made the biggest impact on diagnosis. And that makes sense. History is mostly passed through some filter in pediatrics, but the exam is the exam. It's available to us without a filter. We just have to take the time to do it well. So that means do a great exam. The skin, look at all of it. Range every last little joint. Do a thorough and good cardiovascular exam, neurologic exam, GI and GU. Fluorescein the eyes for corneal abrasions. Evert the eyelids. Look everywhere. You just might find out why the child is actually here and what to do about it. Of note, in this same study, screening laboratory tests, except for urinalysis and urine culture, were of little help. Still, the differential is wide for the fussy infant. I'm basically telling you to look him up and down and all over his little body, and the answer will somehow magically come to you like an illuminating ray from above. Well, maybe it won't be that clear, but chance does favor a prepared mind. Now the moment that you've been anticipating since you pressed play. A way to remember the most common and concerning causes of a fussy infant. That's right, a mnemonic. This one will help you take all of your past experience, your clinical skills, your book knowledge, and apply them to the fussy infant in front of you. Why are you still crying? Well, it cries. I, infection. T, trauma. C, cardiac. R, reflux rectal or reaction. I, intussusception. E, eyes. S, surgical. Use this to run through the causes of the fussy, seemingly well infant, and you won't miss anything dangerous. This is Ingrid. She's 4 months old. She's fussy. Mom says over the past day or so, she's crying a lot more than usual, maybe eating a little less. You see little Ingrid, and she is consolable to Mom, but readily starts crying again and appears upset. Maybe she's in pain, hard to say. You do a great physical exam. Head, eyes, ears, nose, throat, chest, abdomen, GU, skin, everything, and nothing. So this isn't a red light, but she's also not really a green light either. Well, yet. She's a yellow light. Caution, we need to probe, screen, and stratify. The Poole study I mentioned before about physical exam being your best bet also looked at screening tests. Routine screening was unhelpful unless we're talking about the urine. So in Ingrid's case, you see this girl as a bit inconsolable. Something just doesn't settle right with you. So you realize that she is young, she's at risk for UTI, and that this fussiness and inconsolability may be her developmentally and age-appropriate way of saying, "Hey, I'm having some dysuria over here." Well, Ingrid's UA was positive. Infection was the culprit. UTI is far and away the most common among boys and girls. Meningitis is much less common, but the morbidity, of course, is much higher. Remember, we can't reliably use the absence of meningismus in an infant. We may only see fever in the neonate, for example, or fussiness in the young infant, or irritability or poor appearance. Thinking broadly about infection, we can also see on the other side of the coin simple, common things like candidiasis can cause an infant to be fussy, in the form of both diaper dermatitis and thrush. Just think how you would feel if you had a mouth full of yeast. You're not going to miss this one, but it's good to know that candidiasis is a legit cause of fussiness. You may not have to go further. One classic pitfall is to miss a source of fever or just fussiness. Keep in mind that streptococcus likes anywhere that's warm, moist, and unexposed. For example, the perirectal area. So spread the buttocks to be sure you don't see a beefy red rim of cellulitis. Diaper dermatitis, also known as irritant contact diaper dermatitis, IDD, is the result of the combined influence of warmth, urine, moisture, friction, feces, and secondary infection. That's all old hat. Consider also something that's not so run-of-the-mill, Jacquet's dermatitis. It's a rare, distinctive, severe variant of IDD. It's characterized by punched-out erosions or ulcerations with crater-like borders that's typically associated with frequent liquid stools, poor hygiene, infrequent diaper changes, or occlusive plastic diapers. It's more common in children with chronic diarrhea or incontinence, like those with spina bifida or Hirschsprung disease, but it can be seen in poor social situations as well. Treatment of Jacquet's dermatitis is similar to that of just run-of-the-mill diaper dermatitis, but it also includes controlling the moisture. Frequent diaper changes, using diapers lined with absorbent gel materials, and application of barrier ointments are primary strategies. Inflammation tends to respond to topical low-potency corticosteroids and secondary infection to topical antifungal or antibacterial agents. Now, you may think, I'm not going to make this diagnosis. And maybe that's true, but as people see us often for what should be a primary care visit, it's empowering for us to know this kind of stuff too and to help guide our patients. The differential diagnosis of Jacquet's dermatitis includes perianal pseudoverrucous dermatitis and granuloma gluteale infantum. Perianal pseudoverrucous dermatitis. That's a mouthful, right? It presents with papules and nodules located at the perianal area. Granuloma gluteale infantum presents with uniform, reddish, purple oval nodules. Both of these can represent an unusual inflammatory response to some long-standing irritation, candidiasis, or the use of mid to high potency topical corticosteroid preparations. The point here is that diaper dermatitis may not be so ho-hum. It may be, nah. This is Tommy. He's 2 months old. His mother says that she left him on the couch for just a second, and he rolled over and fell off the couch. When can a child reliably roll over? About 4 to 6 months. Is it impossible for a 3-month-old to roll over? No. For a 1-month-old? Well, sure, but much less likely. Stay vigilant. Nothing is impossible, but people can surprise us, and we just need to have a good sense of what is highly unlikely or at least improbable. Ask, that's good. How long has he been trying to roll over? When did that start? Look for inconsistencies in the history. Babies may start to make attempts to roll over as early as 1 month of age, but that is an exception to the rule. Only about 10% of babies can roll over by 3 months, 50% by 6 months, and 90% achieve it by 9 months. So here's Tommy. He's crying, and he comes to us with the T in it cries. Trauma. Be alert. We may not get a chief complaint of fell. In children with accidental trauma, the babysitter may not be forthcoming for fear of consequences. Or in the case of non-accidental trauma, really we should call it for what it is, physical abuse, they may come in to be seen with a completely unrelated chief complaint, often something that's very inconsequential. They do this for a very cynical reason. To have something documented that there was an innocent reason for the visit, they're hoping you're not going to ask, and that we don't pick up on the abnormal fussiness, and that we don't do a good exam. They hope that we'll document a normal exam so that they can put the blame on the next person who has physical responsibility or custody of the child. It's sickening, but it happens. Now, that's not to say that this presentation only happens when there's family disruption. Any person of any walk of life can abuse his child. This is just why we always need to consider it. The more vague the story and the more vague the complaint and the fussier the child, we worry. And this is why we carefully look at all of the axial skeleton, at all of the bones. We palpate and we move every joint. Trauma may be accidental, it may be birth-related, or non-accidental. Keep your mind open. Let's consider 3 babies, all a week old, and all brought in for a swollen head. One of them will be totally fine, one will possibly need some screening, and one you'll need to admit. This is an example of why a good history is important, but a meticulous physical examination is essential. Based on a few critical findings, treatment and disposition are radically different. Here is baby number 1. The chief complaint, a swollen head. He kind of looks like a cone head. He doesn't appear to be particularly bothered by it. This is caput succedaneum. Caput meaning head, and succedaneum meaning that which follows, that which succeeds something, like a second little cone head in the back of the child's skull. Now, since we don't go around speaking Latin all day, you'll just hear it called caput. It's cone head from pitting edema after constant pressure in, say, a prolonged or difficult delivery. Caput is a serosanguinous subcutaneous fluid collection under the skin above the periosteum. Basically, it's edema caused by scalp pressure against the dilating cervix. The main point here is because caput is subcutaneous, remember, caput subcutaneous, it's on the presenting part of the neonate's head, and the swelling crosses the midline and suture lines because caput is subcutaneous and the edema is above the skull, resulting in an elongated appearance of the head. It's benign, and it happens in about 1 to 2% of deliveries, usually with vacuum assistance. It regresses in a few weeks. Very rarely it can calcify, and it almost never gets infected. Really, it's a benign finding that can be safely monitored as an outpatient and also by the pediatrician or family doctor. Baby number 2 is also 1 week old, and she's also brought in for swollen head. But this baby is different. Unlike the cone head caput, this baby has a distinct focal lump on her head. When you palpate, the fullness does shift a little from under the finger to the adjacent skull. You release the pressure from your finger, and the lump immediately refills, and the appearance is identical to the way it was before you pressed on it. This is blood in the periosteal space. It's like a soft, squishy stress ball, full but gives with pressure. This is a cephalohematoma. It can happen in a prolonged second stage of delivery or if forceps are used. It's a small hematoma within the periosteum, so it won't cross suture lines. In the case of a cephalohematoma, it's usually birth-related, but just be sure to consider blunt trauma after birth as well. Usually no further workup is needed, but the blood that will eventually absorb will give the baby an extra bilirubin load that he doesn't need, so jaundice can be precipitated with a cephalohematoma. You may also want to check the total bilirubin. Baby 3, also a week old, is brought in for a chief complaint of, yes, swollen head. He actually doesn't look as well as the other two. He appears to be a bit less vigorous. It's really the child's general appearance that's the first thing that you notice. He's not toxic, he's not obviously ill-appearing, but something just doesn't seem right. At first, you don't actually see what the mother is talking about. The head isn't particularly... Oh, wait a minute. Yep, you do see it. You change your angle of view and you see it. It's a large, swollen area that easily moves to the dependent part of the head. This isn't just a little molding of the scalp that caused subcutaneous edema. This isn't a focal balloon bump. This is a sloshy, amorphous, shifting fluid collection, fluid that is actually all blood. This is a subgaleal bleed, and it is life-threatening. Here, there's bleeding under the galea. Usually it's due to a difficult delivery and vacuum assistance, and the baby's scalp has sheared slightly from the skull. There's no structure there to stop the bleeding, to tamponade it off, and sometimes the child can present in hemorrhagic shock. Remember, the neonate only has a blood volume of 90 mLs per kilo. So if you're born at 3.5 kilograms, that's only about 300 mLs of total blood volume that you're born with. That's about the amount of fluid in a piggyback solution for IV meds. It's tiny. A 10% loss here is only 30 mLs. Another complication of subgaleal bleed, of course, is disseminated intravascular coagulation. The mortality rate of subgaleal bleeding is up to 15%, and the diagnosis is clinical. In subgaleal bleed, you'll see a boggy, sloshy scalp that will shift with positioning. Again, the child is either irritable or depressed. IV access, serial hematocrits, and DIC studies, blood transfusion is needed, surgical consultation, and a NICU admission. This is Carly. She's 2 months old and she just won't eat. All was going well with her until suddenly this morning she seemed extra fussy and she refused even to allow the bottle of formula to her lips. There's no previous history. There's nothing else going on. Her exam shows a restless child, but no other findings except what? You find her heart rate to be 230, way over anything physiologic, way over sinus. What's going on here? When you see a heart rate consistently above 220 in an infant or a child, or above 180 in an adolescent or young adult, think supraventricular tachycardia. Now, that's not to say that the tired, ticked-off, febrile, and dehydrated young child can't have a sinus tachycardia in that neighborhood briefly. If you're unsure, look for an acute onset on history, no beat-to-beat variability, and get an EKG. SVT is the most common dysrhythmia in children, and of course, it has its own differential diagnosis. The hardest part, I think, is considering it and diagnosing it. Put the child on a monitor, get IV access, get a rapid EKG. Look for the underlying cause, and look for cardiac sequelae. The child may have been in SVT for a few hours. Look for sacral edema or a low-lying liver edge. Both of these things are consistent with acute congestive heart failure. You can treat SVT initially with ice slurry to the eyes. Take a glove, add ice, add water, tie it off, place it over the child's eyes gently, being very careful not to occlude the nose. Do this while you're getting IV access, so you're getting ready to treat with adenosine anyway. Cardiac causes of fussiness may be a new diagnosis of congestive heart failure. Maybe the child has an undetected ASD, VSD. Maybe he has abnormal coronary arteries or any number of congenital heart defects that may not be known prenatally. Of course, even previously healthy children can contract a virus that may result in myocarditis. Look for tachycardia out of proportion to the presentation and a generally ill appearance. Okay, what can it be when it cries? Infection, trauma, cardiac, and now the R's. Reflex rectal reaction to meds. This is 5-month-old Rochelle. She was born full term without complications. She had a urinary tract infection last month, but she was successfully treated with antibiotics. Today she seems fussy and has been vomiting. Now, here's where it's very important to distinguish true vomiting, which is a forceful expulsion, from regurgitation or spitting up, which is usually a passive mechanical process. All babies regurgitate or spit up. You may get more of a history that Rochelle is formula fed, that she hasn't been pooping every day, so mom has been doubling her feeds. We're starting to get an idea of why the poor child may be spitting up, regurgitating. It's common for infants to spit up after a meal. That little spit up is called gastroesophageal reflux, or GER. But frequent vomiting associated with discomfort and difficulty feeding or weight loss may be caused by something more serious like GERD, so gastroesophageal reflux disease. Trying to sort that all out in the ED is challenging, but an outpatient workup is completely safe as long as there are no other acute concerns. Rochelle's exam is normal. You've looked everywhere except you look again, you spread the buttocks gently, and you see a small anal fissure. Anal fissures are usually from forceful Valsalva, as in chronic constipation. If the child is in the lithotomy position, typically benign anal fissures occur at 12 o'clock and 6 o'clock. Basically, benign occurs at the midline. That's what's expected and what's normal from just extra pressure pushing something out. We should also be aware of the not-so-benign pattern. When you see an anal fissure off the midline, that is, not at 12 o'clock or at 6 o'clock, think of a tear because of something going into the child. Typically, insertional anal fissures occur off midline at 4 o'clock or 8 o'clock. This may be from something innocent, like parents obsessively checking a rectal temp or giving suppositories or enemas too much. The take-home here is that if you have a history of constipation, and if you have an anal fissure midline, and if you weren't otherwise concerned about poor practices or even abuse, then it's just fine to observe as an outpatient. Small, benign, midline rectal fissures just need counseling. The last R is to remind us about reactions. Reactions to medicines the child is taking himself, or in the case of a breastfeeding mother, medications that mom's on. She may not be aware that her prescription med or her herbal supplement may be the problem. Maybe the reaction is to something environmental, an exposure to heat, to light, to toxins, to infestations. This is a yellow light. Probe with more questions. Infection, trauma, cardiac, reflex rectal reaction, and I, intussusception. This is 1-year-old Ian. He was fine yesterday. There was a birthday party, he had a great time, he ran around with his cousins, he tired himself out. Except he's continued to sleep all day today. And that's it. He did get up a few times and he was very fussy, then fell back to sleep. He slept right through getting himself changed, the car ride over here, and on arrival he is still asleep. You see a boy who is well, but lethargic now. There are two main presentations in intussusception. You have the pain and the fussiness, the crying. This one is relatively easy. But there's also the other presentation of intussusception, lethargy, from the crushed GI neurons releasing endorphins. Just be aware that the fussy infant with intussusception may be intermittently fussy, especially in the 6 to 36 month crowd. Most cases happen by about 18 months of age. Okay, so we have infection, trauma, cardiac, reflex rectal reaction, intussusception, and now E for eyes. This is Eric. He's 2 months old. He's been inconsolable since this afternoon. He will just not stop crying no matter what mom or dad does. They can't figure it out and they can't handle it anymore, so they come to see you. He's a healthy boy, born full term without complications. So we go through our differential and we do a great exam, and we fluorescein the eyes. There it is, a corneal abrasion from those razor-sharp baby claws. We treat with a topical antibiotic ointment for prevention of infection and to soothe the eyes. Typically, we use erythromycin. Now, just a caveat. Shope et al. In Pediatrics found that in an ambulatory clinic, during well-child checks, they looked for corneal abrasions and found that half of their subjects had them. We may be seeing something old or healing or asymptomatic when we see a corneal abrasion in the ED. However, if the history and physical examination makes you fluorescein the eyes and you do find an abrasion, go ahead and treat it. Speaking of other common eye trouble that can cause fussiness, think about conjunctivitis. If you find it, is it bacterial, viral, allergic, or chemical? Glaucoma in infants is underdiagnosed. Glaucoma can be seen at birth or develop during childhood. 40% of childhood glaucoma will present at birth, and 85% of childhood glaucoma is diagnosed during the first year of life. Increased intraocular pressures from childhood glaucoma can damage the optic nerve and lead to blindness. The most common presentations for infant and childhood glaucoma include photophobia, excessive tearing, blepharospasm, corneal clouding, conjunctival injection. Remember that pediatric glaucoma therapy is a surgical diagnosis. It's not treated initially with medications as in adult glaucoma. You may see signs of iritis. You may see consensual photophobia or pain with near gaze. You may see cells in the anterior chamber. Now, it is a little unusual, but as they say, premonitus premunitus. Forewarned is forearmed. Okay, awesome. We're figuring this out. It cries. Why? Infection, trauma, cardiac, reflex rectal reaction, intussusception, eyes, and finally, surgical. Sam is a 5-month-old baby boy who was with his parents in his stroller. They were at the mall doing some shopping when out of the blue, Sam started shrieking. He would not stop. The parents arrive and seem like generally calm people who just don't get why their normally calm baby is screaming like a banshee. You carefully look Sam up and down, and you don't fall for a common mistake. You know that if someone is wearing diapers, no matter how old they are, you gotta take a look. And you see a large, swollen mass in his right hemiscrotum. What could it be? Well, we always have to think torsion. We may not see a cremasteric reflex, and we might see a high-riding testicle with an abnormal lie. Or we may see hydrocele, which can be communicating or non-communicating. Both types will transilluminate. They're cystic, they're irreducible, and they're non-tender. An acute non-communicating hydrocele is just in the scrotum. There's no involvement proximally, and these can be monitored and they'll likely resorb. A communicating hydrocele is from a remnant of the inguinal tract. This is actually fluid that fills from the peritoneum. It will change in size during the day or with position. The trouble with a communicating hydrocele is that it's basically a hernia waiting to happen. These are typically repaired electively. But Sam doesn't have any of those. He has a firm, bulging mass that if you were to auscultate with your stethoscope, you may hear some gurgling peristalsis. By the way, the ultrasound probe would show you the same thing. Sam has an inguinal hernia. Boys are 3 times more likely to get them than girls, and usually this is within the first few months of life. It may present with intermittent bulging. It may present incarcerated or even strangulated. The right-sided predominance is related to the later descent of the right testicle and the later obliteration of the processus vaginalis. The incidence of bilateral hernias is approximately 10% in full-term babies and nearly 50% in premature and low birth weight infants. In adults, we're a bit more permissive with inguinal hernias. If it's not incarcerated or strangulated, then they typically can go home with precautionary advice. The time frame for repair is mostly based on getting the adult functional again, not necessarily a medical urgency. In infants, because they tend to incarcerate when they're out, we're a bit more aggressive with getting surgery, and many small babies are admitted to expedite the process. And lastly, when we think of the S in surgical, think of all the things that you have to surgerize, like a hair tourniquet. Look the child up and down. You may find a little sausage digit, or swollen foreskin, or labium, or even earlobe. A depilatory beauty cream can break down the hair fiber, which, by the way, could be human or animal, or even wool from clothing. Sometimes we have to break out the local anesthetic and dig it out with a quick nick with an 11-blade scalpel. Remember to own your physical exam, and you'll find it. Now that we've gone through all of the differential diagnosis of the well-appearing fussy infant, maybe, just maybe, we can entertain the final cause of fussiness, and so, is it colic? It really isn't the right question. I go through the dangerous differential, and if it's not that and the child is well enough to go home, I don't even have to say the word. The parent often chimes in, so it's colic then, right? I say possibly, but we need to arrange follow-up. If, after you've ruled everything out that's appropriate for this visit, and you get a history consistent with colic, sure, you can counsel the parents about colic. Colic follows the rule of 3s. It occurs from week 3 to 3 months of age. The child can cry up to 3 hours at a time, 3 times a day, for 3 weeks straight. Colic really is a parental endurance test. The 5 S's may come in handy. Swaddle, side stomach position, shush, swing, and suck. Maybe another S could be a shot of brandy, but it's not for the baby. Sometimes a car ride can help with the white noise and gentle hum. Ask parents what they've done so far and probe for risky management. Like, make sure they're not putting the child too near a fan that can collapse on him, or make sure they're not putting his car seat on top of a washing machine, for example. All of those are bad ideas. Finally, the fussy infant can have a caregiver that's on the edge. Make sure to pay attention to them as well and ask them if they have anyone to help. Ask if they feel overwhelmed. Sometimes just the acknowledgement of the struggle can really help. Probe a little further and look to see that the child will be safe on discharge. Give parents specific actionable advice, and for their relatives, let them know that the doctor says, I need help from you. For the colicky baby, it's okay to let him cry. Just make sure that he's fed, changed, and you can put him in his car seat in a room and, frankly, close the door for 20 to 30 minutes at a time and see if that helps. It may just save their sanity. If needed, of course, you should ask if it's been so bad that they ever thought about hurting the child. The answer you get may surprise you, and it may be the only opportunity for prevention of shaken baby syndrome. So remember, the fussy infant appears well, and that may be the most dangerous thing he does. Make sure to do a thorough head-to-toe exam, really own the exam, and ask yourself, it cries, but why? Think infection, trauma, cardiac, reflex rectal reaction, intussusception, eyes, and surgical. Finally, after all of your good intentions, children are little people. They're going to have good days and bad days, and that's okay. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.